Yes, yes, yes. Welcome back to Hip Hop Parade, Black Men Talking Health. I am your MC for this evening. I am Oya Gilbert, and we got a really, really dope program for you tonight. Tonight we're going to be discussing prostate cancer, and as you well know, it affects African Americans on a higher level than our white counterparts. And today in the building, I got some fly guests, and I mean that in the most wonderful way. We got Mark Harris, and I got David Fields, and the infamous Mac Roach III. I'll let them introduce themselves. We're going to start off with Mac. And Mac, could you please tell the audience who you are?
Well, I'm a professor at the University of California, San Francisco in the departments of radiation oncology and urology. And my specialty involves urologic tumors, which is about 95% prostate cancer. And I've been working in this field for more than 30 years.
Oh, that's dope. See, that's what we do. We bring the experience in the building. And so we got Mark Harris. And Mark, can you tell us who you are?
Yeah, I'm again Mark Harris. I was diagnosed with the prostate cancer in 2013. So, and since then I've been able to help other people. So I'm a co-facilitator of a cancer support group. I'm a reviewer for the DOD and do several other things. But I just try to help, especially the black and brown community, but everybody who's diagnosed with prostate cancer. Try to help them on with their journey, and then try to help the researchers and try to help them as they find better treatments or improved treatments for prostate cancer.
Wow. Okay, that was a nice intro too. I'm gonna have to let you introduce me when the program come on. The next is we got David. David, please introduce yourself, brother.
Yeah, I'm David Fields out of Wake Forest, North Carolina. 53 years old. I was diagnosed with prostate cancer in November of 2020, and pretty interesting story once we finally get into it. But that's about it.
Well, that's enough. You know what I mean? So look, I want to go straight. I don't play no games, but I want to go straight to it. Dive right on into this. So Mark, tell us, your story and how you came to discovering that. Well, first of all, your journey on finding out you had prostate cancer, and then where you are today.
Yeah, well, okay. Well, I have to go. I said I was diagnosed in 2013, but in 2011, my PSA was 5.3 or something like that. And at that time, they wanted between 0 and 4. But my physician said, well, if you had ridden a bike or had sex, that could have spiked your PSA. So come back in a week. Well, I forgot. So and then two years later, I had to get some medication, and then he wouldn't okay it over the phone, so he had me come in. And if my wife was here, she would say, and Mark wasn't happy about it, and I was not. I went in and I got the, I had to go in for full physical. So my PSA was now 10.8 13.8 or something like that. So now it's got my full attention. So a friend of mine, Dr. Dolores Brown, she's a primary care physician. So I know she liked lentil soup, so I took her out for lunch, and we talked a couple of hours about my case and stuff. She said, Mark, you got to get this done. Check that. So I, got the biopsy, and then so on October 3rd, 2013, Dr. Solomon calls at 8:23 p.m. Says your biopsy came back positive for prostate cancer. You have prostate cancer, and he said, but I'll do everything I can to help you. And because he said that, I said thank you. So he and all during the rest of the conversation, I'm saying thank you, to the point I think Dr. Solomon said, I'm telling this idiot he has prostate cancer, and he's thanking me. So just to be clear, he didn't say it this way, but I'm my paraphrase. Just to be clear, your biopsy came back positive for prostate cancer, and 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 I'll do everything that I can to help you. And I said, thank you, So I hang up the phone, and it's interesting because I realize now, again, this is a decade later, that I took that news and just put it in the back of my mind. And I thought for a second about not telling my wife, and telling my ex-wife and my daughter, because, as I see it, my role as a man is I'm supposed to be the rock, the foundation, the stabilizer of things, and not the reason there is angst and all this other stuff. But, I put that aside after about a minute, called out to my wife, hey, it came back positive for prostate cancer. My wife come running out. She said, what are we going to do? And so I said, this was a Thursday night. I said, I don't know. We're going to have he said we're going to have a meeting on Monday, and we'll talk about, our what we need to talk about as far as getting deciding on a treatment. So my wife is, what are we going to do? I said, I really don't know. I've never been here. I don't know. I don't know what's going on. We gotta work it out together. What are we gonna do? And I said, now you gotta remember I was in the moment. I said, can't you see I'm watching television?
Oh Lord! Wow.
Yeah. Because again, I had never had. There's
there's nothing you could do about it at that point anyway. So you're gonna deal with it Monday. So deal with it Monday.
Absolutely.
Yeah.
And the thing is, you find out at that moment that there's very few things in life that can change your life so suddenly as your name or a loved one name and cancer being in the same sentence.
True.
All the stuff you thought before that, the second before you heard that you had cancer, all the stuff you thought was a priority is now not a priority. And I've had people say, well, my children, my grandchildren. Well, number one thing, are you going to be there to see them?
Yeah,
so
right.
it's always that's going to affect everything in your life, So, and then so that evening I go to bed and because I watched the rest of the movie and I realized the movie was just white noise. So I go to bed now, and there's quiet and tranquility and stuff. So I'm thinking, my human side said, I'm gonna die. But then my spiritual side said, but how do I use this to help others? That's because God has always given me experiences that I can help people, that I can walk in, that I've walked in their shoes, so I can help people from that point of view.
Right.
So that's what I've been doing since then.
Now,
and then, go ahead.
No, I was just saying. So did you? When you decided to say, "Hey, I'm going to help people," had you had treatment, or you still on the weekend talking about I'm gonna wait till Monday?
No, that was that night. That was that Thursday night. I'm gonna help others, And then again, little did I know that my helping others would be my son 6 days later, because he was diagnosed with a different cancer, adenocarcinoma of the parotid gland, and he died 4 months later. But
oh wow,
God is, we were really blessed that I was. I told my daughter, the Bible says it's appointed for man once to die. So that date was already set. But God had blessed me that I was diagnosed first, because my 30-year-old son would not have listened to me if I hadn't been diagnosed 30. Even he knows everything. So we were blessed. We were blessed.
So Matt, listening to Mark's story, is that something typical that you hear as far as the people, saying, hey, they don't really pay attention to it?
Yeah, it's very typical, but also the first thing I'm thinking about is, well, what was the grade of the tumor? We use a system called the Gleason score. Yep. There was a guy named Don Gleason who came up with this system, and basically you can have patients who have low-grade tumors, intermediate grade tumors, and high grade tumors. And if he told me that he had a low Gleason score, I could immediately tell him your chances of dying of prostate cancer in the next 10 years is less than 1%.
That's
but then
news.
if it's intermediate risk, it's a little bit higher, and if it's high risk, it's a bit higher. So really the bottom line is, until you actually find out what the Gleason score is. I mean, that PSA is a little bit of a problem, but the Gleason score is far more important. That's how the cancer looks under the microscope.
Oh, that makes sense. Go ahead, Mark.
Yeah, 100. So 100%. So I So actually, my Gleason score was 3+4, which is a candidate for active surveillance, what they call active surveillance. But, and this is what I try to tell a friend of mine. He's into this liquid biopsy and stuff. But right now they can't tell. But so then when they take the biopsy, they call those cores. They usually for most people they take 12. For me, they took 13 cores. 11 out of the 13 were cancerous. Okay. And of the 11, more than half of that core was cancerous. So even though it was 3+4 in my mind, and the other thing is that the cancer was encapsulated. That's the term they use. That means the cancer. They thought the cancer was still inside the prostate.
Yeah.
So,
well, Mark, let me pause you right there. So when you said you were a candidate for active surveillance, that's according to the doctors you were talking to. I would never recommend active surveillance in a young, otherwise healthy African-American man who's got Gleason 3+4 and a lot of positive cores. That would be, no, you're not a candidate for active surveillance. Now, what happens sometimes is doctors will tell you, well, you could do active surveillance. And then some patients go, really, doc? Oh, yeah, you don't have to be treated. Well, if that was them, or their loved ones, they'd be telling them, no. So active surveillance is a great recommendation for a person with a Gleason score of 3+3. But once you get into 3+4, the only patients who would be reasonable for active surveillance, if you got some guy who's 85 years old and he's got diabetes, hypertension, had a stroke, blah, 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 you get all kind of medical problems, he can live a long time. But you got a man who's got a 20-year life expectancy. I mean, the thing is, when you treat patients with intermediate risk disease with radical prostatectomy, you only cure about half of them. That's with treatment, right? So if you do active surveillance and your PSA is already 10, next thing the patient is going to be a high-risk patient where the success rate's even lower. So although your doctor said you could be a candidate for active surveillance, not everybody, and I would suggest most experts would not tell a young African-American man with a Gleason 7 that you should even think about active surveillance.
So that's correct. See, so that's how I made my I made my decision based on that. Again, because so much of it was and then that's another thing I did. I went to 5 different physicians in 3 different hospitals, three different hospital things there. So to your point, Mac, I got all these different opinions, and then I took so then I did when I had a prostatectomy.
Okay, gotcha. So that's a great point, Dr. Roach, and I appreciate you chiming in, because from doctors, from specialist to specialist, people have different I guess treatments that they would prescribe based on what they think or what their knowledge is. And so that's huge, for the listeners to know, that kind of information, so that it can help make them make a sound decision. Because like I said, none of this is easy.
Well, there are also guidelines, right? So there is something called the NCCN, National Comprehensive Cancer Network. So it turns out that the National Cancer Institute, the largest cancer research institution in the world, has these things that they call, there's certain institutions that are members. And it has to do with institutions that are deemed to be comprehensive cancer centers. And we write guidelines. I'm on the committee that writes guidelines. So every different cancer site has different committees. So I'm on the one for treatment of prostate cancer. And so you can go on, it's in the public domain. You can look up your cancer. So if you go to NCCN, the website, and you look it up, they don't recommend active surveillance for a young, healthy man with intermediate risk disease. And how many cores did you have positive out of how many biopsies?
I had 11 out of 13.
Right. So you actually, not only did you have intermediate risk, but you had unfavorable intermediate risk.
Oh
And
yeah.
you had unfavorable intermediate risk for two reasons. One, you can be intermediate risk if your PSA is between 10 and 20, even if your Gleason score is low, like 3 plus 3. Or you can be intermediate risk if your Gleason score is 7 by itself. But once you have two factors, PSA between 10 and 20 and Gleason 7, you become unfavorable intermediate risk. Or if you have more than half of your biopsy cores positive, you become unfavorable intermediate risk. So you have unfavorable intermediate risk for two reasons, for three reasons actually. Your Gleason score is 7,
Right.
more than 50% of your cores are positive, and
And
you
your
had a PSA over
PSA.
10.
Yep.
So suggesting that someone like you would be a candidate for active surveillance, I would consider malpractice.
Yeah. And it's,
Right.
I'm not sure if anybody suggested that, but it seemed like that was on the table. But seemed like it was. Seemed like it was on the table. You know, but at that time, stuff is
No, I understand.
Yeah.
It makes perfect sense. I want to pivot a little bit, and we're going to come back around to you, Mark. I got my brother David here, who definitely want him to chime in, because his story is just, with all these stories, no matter what kind of cancer you're dealing with, it's always a unique aspect to it. And then there's also some overlap, some things that have some commonalities to it. But David, if you could chime in and share, your journey, I would truly appreciate it.
Okay. Well, to be honest with you, I hadn't given a PSA test any thought until my father suggested it to me. My father, he's a retired colonel. So, he's always at the VA getting checked up, getting treated, doing what he does. So I was around 2018. He said, so you need to go get your PSA checked. So I went and got it checked, and excuse me, it was like 7.5. So I came home and I said, I told him, I said, hey, Dad, my PSA was like 7.5. I said,
Now, how old were you then? What was your age?
2018, I was 40, well, between 47 and 48.
Uh-huh.
So I asked him, I said, well, what has your PSA been? He said, son, to be honest with you, he said, my PSA has been all over the place. He said, it's been as low as like, say, a 1 or a 2. He said, it's even been as high as, I think he told me like a 25. But my father now, I think he's 83. He's never had prostatitis, never had prostate cancer, none of that, right? So I didn't think anything of it. So I'm like, all right, well, I guess it's just in the family. Just got a high PSA, keep it pushing, right? So 2020 comes. I had a new doctor, a new urologist, and he suggested that I get my PSA checked, because he asked me if I'd ever had it checked before. So I think when he checked it, I think it's 7.8. And he's like, yeah, we need to take a look at that. He said, what I'm gonna do first, he said, is I can't remember if he did the MRI first. I think he did the MRI first. Set me up for MRI. Came back and said, yeah, we see a little spot. He said it was like about like the size of, from what he could tell, the size of about a half a grain of rice or something, what he told me. And so then that's when he wanted to do the biopsy. We did the biopsy, and I don't remember how many cores it was. I don't think it was a lot, but he said the Gleason score was like a 4 plus 3, 7, right? But he said it was like more on the aggressive side. And
4 plus 3 would be more on the aggressive side than 3 plus 4.
So I said, okay. And I said, so well, what's next? So he talked to me about the treatment options. So at this time, I pretty much quit listening. I'm like, because prostate cancer, man, I'd rather have, I don't know, well, I guess in your mind, because as a man, you're thinking your prostate. I'm like, I got a wife that's 7 years younger than me. She's beautiful. What do you mean I got prostate cancer? There's no way it's not happening. And so I'm just kind of blanked out at that point in time. But then Rowdy sits in and he's talking to me about the different procedures. I think he said chemo wasn't an option. He said it was either, I think he said radiation or like the robotic, I forget the word.
Prostatectomy.
Prostatectomy, there you go. And I said, well, what is that? He said, well, yeah, I'm going to stick like 6 arms in your abdomen, and I'm going to go in there and be cutting this and cutting that. And I'm just like, man, there's no way. There's no freaking way. And so, I asked him about the radiation, and, then he's talking about incontinence and all these other issues. I'm like, there's got to be another option. I said, this, I'm too young for this. So I told him, I said, all right, well, give me some time, think about it, see what I want to do. So I went home and started just doing some research. And what I found out was, number one, his specialty was the robotics. So he was kind of pushing me in that direction. So when I got home, I started doing my own little research. And that's when I found out about HIFU. And for those that don't know, that's, I think it's a high intensity focus ultrasound.
Yeah.
Right.
And I was like, okay, so basically to go in with ultrasound and I guess destroy the cells and, see what happens. So I started reading the stats on it and, all that kind of good stuff. And so I went back to see him and he's like, so, what have you decided to do? And I said, I'm thinking about HIFU. He gave me this look like, HIFU? Like, why do you know about HIFU? I kind of got that feel from him, like, how do you know about that? Because he didn't give it to me as an option. And he's like,
okay, let me pause you right there. Yeah, break it down for my peoples out there in layman terms. What's HIFU?
Basically, it's ultrasound. So basically, you go into a room, they put you under, they do whatever they do with the ultrasound probe, and I think the term is ablation, I think is what it's called. They go in there and destroy the cells with ultrasound. That's my understanding of it. And so then, he started, how people, when they're trying to handle you, it's like, it's expensive, I'm just like, okay, well, I got insurance, it's not a problem. It's like, yeah, well, insurance doesn't normally cover it. I'm like, so what are we talking about? And he told me straight up. He said it's $25,000. Like, he had the number right there in his head. It's $25,000 a procedure. I'm like, okay, well, I'd rather do that than get cut on. Period. That's not even an option. I don't care where the $25,000 is coming from. You know what I'm saying?
Right.
It don't matter to me. I don't care if I got a, second mortgage on the house or whatever. It doesn't matter to me. Yeah, pretty much. But that was my situation, and that's what we did. And so far, that was 2021. I think April, May 2021 is when we had the procedure. I've been back twice just to do follow-ups. But every time you go back, they want to do the what do they call it? You were just talking about it, Mark, the biopsy.
Biopsy, yeah.
I'm like, nah, I'm not cool with a biopsy, because to me, I guess the way I think about it, like sticking metal probes up in your prostate or whatever there, so that just to me doesn't sound like it's creating a problem more than it's helping.
David, I got bad news for you. The HIFU is not very effective. It's not included in the NCCN guidelines. Now, I don't know what your Gleason score was 4+3. Which means you're at higher risk. Your PSA was 7, but you don't know how many cores you're. So you're unfavorable intermediate risk as well, like Mark was. But the problem is, and a layperson like yourself would not understand what the implications of the data. Actually, I have an extensive file on HIFU papers. And my urologist here will do HIFU as focal therapy. So the ideal patient for HIFU is there's a type of therapy category called focal therapy.
Okay.
Which means that if you can image the prostate and you think that the cancer is limited to one part of the prostate, you can freeze it with cryosurgery, which is freeze to kill that part of the cancer, or you can do high frequency focused ultrasound, and essentially that burns the cancer up in one location. But you can destroy parts of the prostate several different ways. The problem is the biology of prostate cancer. So first of all, most people do not have prostate cancer. They have prostate cancers, plural. Usually the disease is multifocal. It's in other places beyond one little place. So even if the biopsy only shows it in one area, statistically, there are likely to be other foci in other parts of the prostate.
Okay.
So not that many people are good candidates for focal therapy unless they do something called a saturation biopsy, where they take you to the operating room and they create a grid and they biopsy the bejeebers out of you, and they find out there's one little spot of a relatively low-grade tumor. That's an ideal candidate for focal therapy. But the reason that a patient with a Gleason score of 4+3 is not a great candidate for focal therapy is because if you remove the prostate, completely remove the prostate in a patient that has a Gleason score of 4+3, at least half of the patients recur. The cancer comes back, even though the prostate's been removed. And people, wait a minute, I've had patients come to me, I'm a radiation oncologist, right? I've had people come to me and say, well, wait a minute, I don't know why my doctor told me to come see you. He removed my prostate. Well, a lot of those people recur right where the prostate used to be because they cut the prostate out and then they sew the bladder neck down to the external sphincter. And so some people recur in that area, and the other people tend to recur in the lymphatics. So it turns out that cancer can spread to the lymph nodes. And even though a CT scan doesn't show it and an MRI doesn't show it, microscopic disease can be low the resolution. And one of the problems with HIFU is like, well, what should your PSA be if your prostate is still there and you had HIFU? Now, when you take a patient who's had their prostate removed, the PSA should be undetectable. That means that the normal PSA, as Mark alluded to, is supposed to be up to 4. After the prostate's removed, what we look for is a value that has a less than sign, less than 0.02. That's ideal. That's the kind of number you're looking for, undetectable.
Right.
When we do radiation on people with high doses of radiation, the prostate is still there, so it can still make a little bit of PSA. And our standard definition for a recurrence is if the PSA starts to rise, and it rises by more than 2.0, okay? But that's because the whole prostate's there. But the criteria for what a PSA should be after HIFU has not been well worked out.
Right.
So when you're followed, you have a normal part of your prostate that wasn't HIFU'd and part of your prostate that was HIFU'd. It's hard to know where that PSA is coming from, and it's hard to know how much PSA you should be producing.
Okay.
The good news is you can still have effective therapy. If the HIFU doesn't work, you can still have your prostate removed, or you can do radiation. And generally, radiation is tolerated better than having your prostate removed. So if your PSA starts to go up and they biopsy you and confirm that you still have cancer, then more people would recommend radiation than not in the treatment of that disease.
Instead of just removing it.
Okay. Yeah, well, I know last time they checked it, I was at 1 on the PSA. So, like I said, I'm keeping an eye on it, and I guess that's really all I got. Well, what's interesting about that is my father was telling me, because he was friends with General Schwarzkopf. I don't know if you remember him, like Operation, I think, Desert Storm. And he died with prostate cancer. And
a whole lot of people died with prostate cancer.
Yeah, and I remember him telling me that
Tiger Woods' father died of prostate cancer.
Yeah.
Stokely Carmichael died of prostate. I mean, I could go down the whole list of people.
Oh, yeah, I'd imagine. But what was interesting...
Cancer. A lot of black men died of prostate cancer or had it and got treated for it. Dusty Baker got treated for it. Harry Belafonte got treated for it. Sidney Poitier got treated for it. I mean, it's like real common. So,
yeah.
It's
what I was going to say, though, what was interesting about Schwarzkopf was that my dad told me like his PSA was somewhere like around 1.7 or something like that when he had passed away. But it's weird because my father's is like off the rails, but he has.
Well, but the PSA by itself doesn't tell you anything. If the what you don't know is what his testosterone was.
Right.
So, and also
Right.
prostate cancer can de-differentiate. Like normally when we talk about the Gleason score, we're looking at categories like Gleason 6 or less, Gleason 7, Gleason 8 to 10. But some people have what we call anaplastic thyroid cancers. So these are neuroendocrine neuroendocrine prostate cancers. So these cancers can become very aggressive. And when they do, they tend to make less PSA. So PSA, 99% of the time, you can use it to monitor people, but in small percentage of cases, people don't make much PSA. So if they have a very high-grade tumor, they can have a low PSA. The other thing is that a PSA is not accurate if your testosterone is not in place. So if you take a man, like if your father was put on given medication to eliminate the male hormone testosterone, even if the cancer had spread, the PSA could come down and be relatively low, even if you have widespread disease. So it really, if you don't know whether a person has a prostate or not, you don't know what that PSA will mean. If you don't know what their testosterone is, you don't know what that and if you don't know which direction the PSA is going in. If you have a PSA of 1.5, and your prostate's gone, but 6 months ago it was undetectable, that's a big difference than somebody whose PSA is fairly stable at a low level.
So
Right.
Mac, so I'm just thinking, like when you say this, I'm going to try to make a comparison. So I have multiple myeloma, and so there's things you can test in the urine and the blood, and so I consider like the PSA like an indicator, but then they do the bone marrow biopsy to be like, to say officially this is what it is. And that kind of sounds, is that a good comparison to make it in layman's terms?
Yeah. So the diagnosis, see, there's a syndrome called monoclonal gammopathy of undetermined nature or something like that. So if you see a person that has some of the markers of myeloma in their serum, they're producing these proteins, they may not have myeloma. You want to biopsy their marrow and look at it on a microscope and say, yeah, this is multiple myeloma. And then there's different types and there's different categories. So and it's actually, and myeloma is more common in Black men, like prostate cancer is more common.
Exactly. And that's and that's the reason why, we had this program, because we are trying to make sure we shed light on one of the things that I say is, first and foremost, as African American men, especially in that certain age bracket, I would say in the 50s on up, we've been having taught that thing, about, pride. And I always say, don't let pride stand in the way of prevention. We got that old kind of stinking thinking of, first of all, we don't even go to the doctors, and then to even try to go get tested. So it's important to make sure we do go get our annuals and things of that nature, because if it sounds like, David, you used, because of your father's situations, that's what sent you to decide to go to the doctor. Am I right with that?
Well, yeah. Well, I was going to the doctor, and and I was, they were doing like the prostate. I had the digit exam done, what I'm saying, but it never really looked into the PSA or anything like that. And it wasn't until, my dad talked to me about it, and I was just like, yeah, let me go ahead and get checked, because I was already beyond 45 years old. So I'm like, okay, I'm 48, 47. I think it's 47, 48. I was like, okay, it's time to go get it checked, which I'm glad I did, because otherwise I felt fine. So I probably wouldn't even have looked into it, because a lot of times we tend not to address an issue until it starts hurting.
We usually.
Yeah, well, most people that get prostate cancer have no symptoms.
Right.
And people that have urinary symptoms is usually not from cancer. It's from what we call benign prostatic hypertrophy, just an enlarged prostate. So you can have trouble emptying your bladder or getting up a lot at night. So people with urinary symptoms frequently think, oh man, maybe I got prostate cancer. Most people with prostate cancer don't have any symptoms. And the other thing is that, we won't have enough time to talk about all the areas, but there are a lot of myths about prostate cancer. One is that prostate cancer is inherently more aggressive in black men. Okay, that's a total myth. The fact is,
Wow.
prostate
Okay.
cancer is more common in black men, and it comes on at an earlier age. So black men tend to get prostate cancer about 5 years earlier than white men. We don't know why. It probably is multifactorial: environment, diet. It could be other things. But if you take a black man and a white man, and they have the same PSA and the same Gleason score, and they get the same treatment, the results will be the same. So being black is not, and I can tell you that there are, like 30 years ago, there were all these papers claiming that prostate cancer was inherently more aggressive in black men. And I was one of the people saying, no, it's not, no, it's not, no, it's not. And now they acknowledge
That it's
that,
not.
oh yeah, well, it probably is not. Okay, I just published a paper last year on health disparity in prostate cancer, summarizing the reasons in the data. And I have another paper which is under review, looking at artificial intelligence, where we took pathology specimens from more than 5,000 patients, of which 900 were African American men, and they were all treated on prospective studies where the quality of care was controlled for. And actually, the African American men did a little bit better than the white men treated on those studies when you adjusted for those parameters. So this notion that black men have inherently more aggressive prostate cancer is a total myth. And one of the problems when you get a myth like that, so when I submitted this paper, this more recent paper with artificial intelligence to this journal, one of the reviewers was like, well, how come you didn't do analysis by race? And I'm like, a separate type of statistical analysis. And my response is, look, we've done that repeatedly. There have been at least 12 randomized trials, and 11 of the 12 studies said African American men did as well or better. And only one of the studies suggested African American men did worse. So why do I have to go back and
Spend those
pretend
resources.
like African American
Right.
men did worse simply because you have been affected by the myth?
Right. Wasting resources that could be.
Right. So we'll wait and see what their response is to that. But the bottom line, that's a common myth that prostate cancer is inherently more aggressive in black men.
Yeah. So go ahead, Mark.
Well, I was just saying that there's a study that was done out of the VA that actually it supports that. All the soldiers, soldiers have the same access to care, so it showed that everything was basically equal. Everything was equal. They all received the same care. They all had the same mortality rate. They all had the same treatment. Blah blah blah. So that was.
Well, Mark, that's reassuring, but I can tell you that there are other studies, not specifically in prostate cancer, but also in some prostate cancer studies. If you look at, for example, there was a paper many years ago out of Kaiser, and they looked at survival rates among black men in Kaiser and white men in Kaiser, and they concluded that prostate cancer was inherently more aggressive in black men. And the bottom line is this: even in healthcare systems where you get equal insurance, black men do not get equal care. For example, there's studies showing, you look at the use of cardiac catheterization. If you look at the use of bypass surgery, if you look at the use of kidney transplants, there's all these people. They all have Medicare. They all had the same thing, and they also did a study once where they went to the American Medical Association. They went to a meeting, and they created these videos where they had actors pretending like they had, heart problems or whatever. And they presented these cases to the doctors, and they had black patients and they had white patients with identical situations. And the doctors managed them differently.
Wow.
So the VA is not as bad as some places, but there's a plethora of data published showing that black people and white people don't get the same treatment, even if they have the same insurance. And there's also data to show that black patients get better care from black doctors.
Facts. That's
Yeah,
facts.
it's funny you say that because I made it a point to seek out black doctors. You know,
Yeah, that's true.
And it's
I had one
smart.
from Senegal, but then when my insurance plan changed, I had another brother, but he's I think he's from the Caribbean.
Yeah, starting out with pediatric care. There's studies starting out with little children working up.
Yeah.
Black doctors do better. This is part of the reason that when we talk about diversity, equity, and inclusion, we're not talking about diversity, equity, and inclusion because we want more jobs. We're talking about because the care that our people receive is different.
Yeah.
And we want better care.
Right.
So we need to have diversity, equity, inclusion, because I can tell you 30 years ago when I was arguing with all these crazy people about why I said prostate cancer is not inherently more aggressive in black men, they all disagreed with me. But we need black people to challenge dogma when the dogma is making us look bad. So basically what they were doing was giving us shit care. Ooh, Scoop.
You right.
You can censor that one out. Care, and then they were blaming us.
Right, exactly.
They were saying it's your fault because we can't help you got them funky genes like that make you die at a faster rate. And in fact, it wasn't our genes, it was access to care, quality of care, and so forth that had nothing to do with any inherent genetic aggressive disease.
So, there's statistics out there that support everything you just said, Dr. Roach. And, to your point, it's important we have to infuse inside the healthcare system more people that look like us. And I'm not just talking about from the doctors, I'm talking about the whole spectrum of healthcare. And then one of the things, and I want to talk about quickly, and I know we're running short, one of the things I wanted to talk about is the mental side of it. And I think, David, you kind of alluded to that. I had a buddy of mine who was talking on another episode about how he had to get his prostate checked and he didn't really want to do it. So he asked his black doctor, let me see your hands. And then, he was like, so they went and got a different colleague. It was a woman. I heard that. Yeah, she had smaller hands. But I guess my point is my uncle did have his prostate removed and everything. He talked about the emotional aspect of it. And I just wanted to see if you guys would touch on it. And Doctor, I would love for you to come in afterwards. There's an emotional side to this. We talk about our manhood and how that, when that happens, things change, as we well know. And so, Mark, I wanted you to touch on it real quick. And then David, I want you to touch on that. What was the thought process when you think about that?
Well, in my case, I tell my guys in the support group, keep the main thing. Is because I know a lot of guys who didn't get their prostate checked out because they want this ideal sex life. And then after a while, I said, hey, if you did, you're not gonna have no sex. Trust me, you're not gonna have any sex. So it's all about being here, and I just kept that focus. I guess I'm not the typical macho thing because my thing is it's all about I want to be here for my family. I want to be here. I just want to be here. Period. And I just stayed on that one track. That was my one lane. I want to be here.
And I think it probably would also depend on your age and your situation. Yes. I'm sure that's a huge factor in it. David, what's your thoughts on that?
Well, at first I was in like just disbelief, like nah, and then I got angry. You know what I mean? I was because it's like you want to understand, like this is like kind of like the whole why me scenario, and then you start going through, okay, why did this happen? And then I'm starting thinking about, just my relationship with my wife, and you know what I mean, and just being able to be being functional as a man, because I've never dealt with prostate cancer before, so you don't really know what to expect. All you think of is worst case scenario. Right. It's like being sentenced to death almost. In my mind, it was at the time, because I didn't know anything. I'm like, it's over, So I was a pain in the behind for a while around the house. You know what I mean? Just processing it and dealing with it. But then once it all started to settle in, I was like, okay, we we can deal with this, you know?
The thing is that no matter what it is, it's okay though. You know what I mean? Because cancer, no matter what type of cancer it is, it's a dark place when you talk about it. And so, there's different emotions that people have to go through, and it's okay to be in it. What I've always said, it's okay to go through emotions. The issue is you can't stay there. You can't stay there, or you can't fall in the rabbit hole and just, and spiral down to a path of just, I hate to use it so simple, but the woe is me thing, because as Mark indicated, there is still life, and I get it. Our sex, we put a lot of value on having sex, and I get it. But the point is like the thing is, if you're not here, when I talk about multiple myeloma, or I have a friend of mine who says he don't want to go to the doctors, and I'd be like, why? He's like, because I don't want to know. I'd be like, well, let me tell you something. Yeah, you're gonna find out. You're gonna find out.
You're gonna find out.
You can find out now and have maybe a chance to do something. But if you don't do nothing, regardless of whichever decision you make, you are going to find out. And if you find out in the way of just waiting, it could be fatal. And so, Dr. Roach, I'm gonna go ahead and let you chime in on maybe the mental side that you might have experienced with the patient.
Yeah. So the thing is, first of all, the point you brought about age is really important, because it turns out that by age 70, 50% of the men have erectile dysfunction anyway. Right? Their things are starting to go down. Now, and the other thing is that erectile dysfunction is treatable. So it turns out, I remember one time I saw a patient, he had a radical prostatectomy, and he was looking depressed, and his wife looked like Marilyn Monroe. I mean, literally sitting there, and I'm not really into Marilyn Monroe types, but that's what she looked like. And
that was a nice way of saying it.
I told him a story about how when I was a resident at Stanford, I had this patient that came in, and I asked him, we were told always after he had his radiation some years before, and I asked him, so how are you doing, blah, 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 what about sexual function? He said, well, about 5 years after radiation, my sexual function went away, but then I got an implant. And he said, before the implant, my wife used to have 1 orgasm, now she has 3. And I was like, oh, well, okay.
That's gangster.
Okay, so then, wait a minute. Okay, so then the next patient came in, and he was looking all depressed. And I asked him, I was like, so how are things going? Fine and everything. And I said, what about sexual function? He was like, no. I told him about the guy who had left. He said, can I talk to him? I want to talk to that guy, right? So I told this other guy whose wife looked like Marilyn Monroe, who had the surgery, who came to me. I told him the story. And so his wife had not said a word the whole time. She's sitting there, I'm talking to him, and I said, I had this guy, his wife, he said my wife used to have 1 orgasm, now she has 3. That man's wife said, he wants one of those. My resident, who happened to be a woman, turned red and blushed and everything,
Yo, that's a dope
She
story.
said he wants Marilyn Monroe said he wants one of those.
Right.
That's what he needs.
She wasn't playing
Yeah.
with it. Well, look.
And then the other thing is that was before we had Viagra.
Got you.
So now there's a lot of people. I could tell you all kinds of stories about Viagra. This is my only story I'll tell about this, because this guy, I thought he was married to this lady because they used to come in together, and then turns out they were getting apart and everything. But every time they would come in together, I would ask him, did he need Viagra? And his partner would say, no, I don't want him taking that. Blah, 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 blah. And then they would leave. And then one time they left, and then they were in the lobby. And then he came back to my office and said, hold on, let me ask Dr. Roach. He came back to me, he says, it's working good, but I don't want her to know. So can you hook me up with some more?
Yo, that's dope. Listen, Listen, I want to tell you guys, I appreciate y'all coming on the show. That was a great way. That was a mic drop moment right there. There we go. But, so listen, it's important that you go get your annuals. It's important to get checked. Obviously, if you have somebody in the family that has any cancer, is typically something you might want to investigate as well. But I close my show out, I close my show out the same way. And I know I got some older gentlemen on here. I hope I don't lose my black card on this one. So I close out my show the same way every time.
Older gentlemen? What do you mean by older gentlemen?
I'm old too. Old too. I know.
Watch out now. Where you going with this? Older gentlemen.
Well, okay. So let me just jump right into it then. I'm going to say this. When you want to get hyped up and you're trying to do your thing, and I'm talking about your personal life, and you're going to get hyped up and geeked up, I want you to give me a hip hop song that you would like to play. It could be old hip hop, new hip hop, whatever it is. And I'm gonna start with you, David, because you look like you got something.
Get hyped up. I would say X gonna give it to him.
Oh, okay, DMX. I love it.
X is coming. Yep.
All right, Mark, do you got something for me? You smiling? What you got?
I go to work.
Kumo D.
Kumo D. I go to work. Yeah, that's a dope joint right there. I go to work. Kumo D with the he kept those Star Trek sunglasses on all the time.
Yeah, he did.
I'm
back. We batting 1,000, Dr. Roach.
Well, I'm the OG in the groove right now. So listen. So I'm going back a bit further. I go dance with the music. Slide the family stone. I'm a runner. So I go out and I run around Lake Merced, and I have my music on, and I have dance to the music.
Listen,
there you go.
So listen, the dope thing is Slide the Family Stone. That particular song, Dance to the Music. I'm gonna tell you a little nugget. It was sampled by DJ Mark the 45 King, and it produced a song that Queen Latifah spit his songs, and it was called Dance to the Music, and it was a dope track. So that song and a lot of hip hop, especially the earlier hip hop, comes from the music that you grew up on, brother. So listen, I appreciate y'all joining the show. This was a really dope episode. I hope my listeners learned a lot. And as I always conclude, we say peace out and keep 5-0 guessing.